And that's by design. So one of the physicians on my CME advisory committee last year said, why don't we have subspecialty updates, speed dating of sorts, where we hear a short presentation from multiple different specialists. So this is the first of that for this season. We'll have another one later in the year where we have a few subspecialty updates. So that's why these unrelated presentations are both today. So I'm going to first introduce our first speaker, and then after Dr. McQuade is done, then Nancy Murphy will introduce Colleen. So Dr. Debra McQuade is an assistant professor in the Division of Pediatric Behavioral Health. Dr. McQuade first received a PhD in developmental psychology and then later her MD degree, both from the University of Connecticut. She completed a residency in adult psychiatry and a fellowship in child and adolescent psychiatry at Dartmouth. She has worked both in the outpatient and inpatient psychiatric settings, caring for children and adults. She currently works as a child and adolescent psychiatrist at Primary Children's Hospital Center for Counseling, and as you can see, medical director of inpatient services at Wasatch Canyons. Her clinical interests include mood and anxiety disorders, psychotic disorders, as well as other psychiatric and behavioral disorders that manifest during childhood and adolescence. Comments from one of her colleagues include, Deb has been a delightful addition to our division and has jumped into her leadership role to really drive necessary changes to our inpatient psychiatric unit in a meaningful and evidence-based way. Please welcome Dr. McQuade.
Thank you for that introduction. I haven't been speed dating before, so. And my name is Debra McQuade. I'm here from Wasatch Canyons, and I'm here to talk to you a little bit about a research project that's been undertaken down there 12 or 15 miles from here, I'd say. My disclosures, I have nothing to disclose. The learning objectives here briefly are, hopefully you will be able to identify 3 psychiatric diagnoses that we can use, second-generation antipsychotics by virtue of FDA approval on the pediatric population, and perhaps then recall at least 3 second-generation antipsychotics that have approval and what their associated diagnoses are. Before I start, I want to make reference to the group that has been working with me on this project. This includes some people who may be in this room. Rich Martini and Sharon Saldana actually started this project and spearheaded most of the initial stages. Karen Valentine is our statistical wizard. Kent Korgensky and Phil Johnson are wizards of a different sort. They get data to us, and Yen Johnson joined us as one of the medical students who was instrumental on one of the projects I'm about to report. So there's only 2 things you have to know in order to understand what this research project is about. You first have to understand that for second-generation antipsychotics, their adverse event burden is very high. They're really not pleasant medications to have to prescribe to children, and we prefer not to. However, we are doing it at an extraordinarily high rate currently. They have more metabolic problems than the extrapyramidal symptoms that are more associated with first-generation antipsychotics. And one thing that's important to know is that for all the metabolic problems that occur, these affect children who take these medications more than they affect adults. So that's the first thing to know. The second thing to know is that prescribing these medications to children has stirred up a certain amount of controversy, both in the public as well as professionals who have made some reports about this. And this is primarily based on the fact that our off-label prescribing rate for these medications is extraordinarily high, reported in the literature between 65 and 95%, depending on circumstances. And that high rate in itself calls into question the kind of decisions that might be undertaken or might be made by the doctors who are prescribing them. Certainly for people that are concerned about this practice, it brings to mind a need to perhaps review the kinds of decision-making that's undertaken before these medications are prescribed, perhaps in a way that allow us to curtail that in the future. Just a couple of quick sort of references. This is just selected at random, the kinds of comments that have been made over the last 10 years or so. And this variety is from Christopher Krell, kind of famous child psychiatrist, mixed up with consumer news and Kaiser Health news. And then here's an interesting collection of consumers who are also angry, it looks like. My goodness. There's this one over here, hiding in the back, psychiatry hooking kids on drugs and labeling children for profit. I guess these are angry people, and that's not necessarily completely specific to my talk, but I bet these folks would not like me to prescribe SGAs to their children. So those are the two things that you need to know. And with that said, the group decided to investigate or to explore what kinds of prescribing practices were taking place on our campus. The initial goal was to see whether or not we could make some changes, some recommendations and some changes. That's not what part of my talk is about. My talk is about sort of the preliminary work and the interesting findings that we identified. So we had access to some data on the prescribing practices of the LIPs at the campus, and we decided to limit ourselves to the inpatient and the residential treatment center groups. We did a retrospective chart review of all children who were in those programs during a one-year period, and the admission criteria, other than being admitted to those programs during that time, was that they had been prescribed an SGA during that time. The data of interest will be either the number of prescriptions that were written or the number of patients that fall under a certain category. And the analytic method throughout the 5 small studies I'm going to report are not parametric, based on frequency. And because there are 5 of these, I'm going to go along at a pretty fast pace. They're pretty simple, but if you have any details of interest, I have written a draft summarizing these, and you can ask me for that draft by email, and I'll send it. So the first question that we asked ourselves was, what exactly is going on for our doctors at our campus? What's the extent of off-label versus on-label prescribing where we are? And what we found is that there were 77% of our prescriptions during that year were off-label. And that was reassuring to us to explore this data set further because it's fully consistent with what was being reported in at other hospitals and other databases. So I said between 65 and 95% off-label, and there we are, kind of in the middle. So the other thing that was reassuring is that when we rank ordered the frequency of prescriptions, Seroquel or quetiapine being the most frequent, and Haldol I put on there. It's not a second-generation antipsychotic, but it was one that came up during that year period. That rank order also seems to match, at least for that prescribing year, what other papers were reporting. So we felt that we had a reasonable representative sample, and we're satisfied about exploring a little further. So then the answer to the first question is, what's the rate going on for us? It's exactly consistent with what the national reports are. For us, was 77% of prescriptions were off-label. So the next question was, is there any way where we can find some organization within this 77% of off-label prescribing? And it occurred to us that there might be some way we could actually identify whether prescribers were indirectly influenced by FDA recommendations. And we did that by choosing to identify a third category of prescribing. So not just full off-label and not just full on-label, but we decided to sort all of our prescriptions into a third category, including a third category of partial off-label. And partial off-label would mean, I'm going to skip ahead just a bit. This table is representation of all the FDA-approved ages and diagnoses for second-generation antipsychotics. Over here on the right, I'm sorry, wrong button. Over here on the right, you see there are only 3 diagnoses that child psychiatry has that has associated FDA approval. And you can see here exactly what medications and ages they are approved for. So for a partial off-label, let's see, if we take autism and aripiprazole or Abilify, you can see that aripiprazole is approved starting at the age of 6. for individuals with autism. Now, if we prescribed that to a child age of 6 who had bipolar disorder, that would be off-label, but we would consider this, in this case, partial off-label because it's a medication that has approval for some other age group or some other diagnosis. And that then identifies a level of risk that we're going to talk about later, with full off-label conferring the highest risk of harm to a child or patient, full on-label conferring the lowest risk, and this partial off-label conferring an intermediate risk of harm. And this is the data that fell out, which was really very nice to look at. Here's, whoops, got to get this button down. This is that original 23% on label from that first representation. And this is the 77 broken up. And what you see is, of those off-label prescriptions, huge proportion, over 3 times as much, are really partial off-label. That is, which again, less risky perhaps than full off-label, and perhaps giving us some indication that prescribers are sensitive to level of risk when they're making decisions about their patients. And we actually looked to see if that pattern was consistent with other categories of patients. We looked at males versus females. We scanned through people who identified as belonging to an ethnic group versus not. This pattern was pretty consistent throughout, so we felt confident that that was probably something genuine. So the second question is, excuse me, do FDA indications influence prescribers' selection of an SGA when they're prescribing off-label? It looks like they are sensitive to that. And the important point is that unlike descriptions of prescribing practices that are superficial and only look at off and on label, these data really tell us that something important is going on beneath that surface, and that prescribers are, have the best interests of their children, their patients in mind. Moving to the next study, we then decided to see, well, what happens for children that have diagnoses, that actually have FDA indications? Let's pull them out and see what happens. So again, that would be those 3 diagnoses. Oh, 3 buttons is clearly too many for me. These 3 diagnoses, and we had about 95 children from that population that we could look at. And so this is what the outcome was for them. This is the outcome. Now, this is that original data, that first one, that's 77% off-label and 23 on. But if there is an indication available, you can see that these flip-flop, that 65% of the prescriptions are on label. So apparently it's another avenue for influence for the prescribers. Now, there was one outcome in this data that was quite unexpected, and I actually could spend the whole 30 minutes talking about this, and I'm sorry that I can't, but this is the overall off-label prescribing from that data set, and this is now splitting by the 3 diagnoses. And what you can find is that the autism spectrum disorder kids do not benefit from this trend. They're still getting a very high rate of off-label prescribing. That was a real puzzle to us. We tried to see if there was something in the data that could help us. We thought maybe they were different age, or maybe they had more medical problems, more coded diagnoses, and those differences were not significant. We then wondered if they had more experience with medication, so we looked at number of previously prescribed antipsychotics and number of previously prescribed psychiatric medications, and those weren't significant. So we're just puzzled, and we don't know what that's about. With some reflection, we think these data perhaps are inadequate. This is more objective data. These are subjective reports from parents' memory, so it's just possible that that's erroneous, but there's nothing in this study that helps us sort that out. But that was a pretty interesting finding. So again, for our third question, do prescribing practices change for diagnoses that have FDA indications for SGA use? It looks like they do, with the exception that the children with ASD do not benefit. Now, here's another category of patients we thought might be interesting to explore. What prescribing practices exist for patients who are too young to be excluded, too young to have any FDA indications? And going back to this table, you can see all those white zones represent children and diagnoses for which there are no indications. So we decided to pull out everyone under the age of 9. We had to really exclude the autistic kids here because there aren't that many of our population. We didn't have a huge pool. As a matter of fact, we only had 13 children between the ages of 6 and 9, and that represented 20 different hospital episodes. So they were either there more or they were there for a really long time and administratively created a new episode. So that wasn't a whole lot. We then decided to add a little bit. We went up to age 11, up to 12, and we pulled out this time the kids with bipolar disorder who had some indications available. And at that point, we had a group of 31 patients with 40 episodes. And this is what the data looked like. This is for the smaller group, the younger of the youngest, 6 to 9. This is for the larger group with 6 to 11. They look pretty consistent, but what we found out is that, now these are by definition off-label, right? You can't have on-label decision-making here, but it's pretty clear that for young kids, where there are no opportunities to choose an on-label medication, the practitioners are strongly preferring to have a partial off-label medication. So the answer to this question, again, is for this younger group of kids for whom SGA use is necessarily off-label, prescribers strongly favor these partial off-label medications. So the next and final question we asked ourselves is off-label prescribing related to length of treatment? And this question came about because we were wondering, as practitioners dealt with patients over time, might it be the case that they choose less risky medications before they choose the more risky medications? Would they go with FDA indications available or then partial, if not available, before they choose the more risky medications? Now, that was a little bit a tough one to sort out, and it's not the best of the group of studies I want to report, but it is an interesting outcome. What we did is looked at patients during that year that had more than one episode. That is, they came back. And they came back they came back either 1 to 3 additional times that year. And there were about 44 patients that did so. And we took their first episode and their last episode, and we ignored how many were in between. So that's really kind of weak. But essentially, first episode, last episode, and during those episodes, we then sorted their medication choices into risky or less risky, essentially off-label, partial off-label, or full off-label. And when we had those two categories, we looked to see what happened the second time. Did they stay in the same category? Did they choose something that's riskier, or did they go in the other direction? And this is what we found. And I see you there, Karen. You did something fancy for us when we analyzed this. But what we find is that for most patients, between their first and second episode, the doctors are choosing meds. There's no level of change in the risk of their medications. So that's a good portion, of almost 60%. But when they do change a level of risk, they go from a lesser risky med to a higher risky med. So this purple bar represents a change of increased risk. So what that means is between the earlier stay and the later stay, it looks like the earlier stays had medications that were less risky. Then when those options have failed, they turn to something that's a little bit more risky. Again, it's a little bit convoluted, this line of thinking, but I do think that it shows that practitioners are trying their best to pick in ways that will mitigate risk for their patients up front, and only as they run out of options do they turn to the medications that are a little bit more risky. Or just say it in a way that I thought of when I was actually thinking clearly. So the question is off-label prescribing of SGAs related to length of treatment? And the answer is when medication changes result in a level of risk change, movement strongly in the direction of increased risk relative to decreased risk. And this suggests that the likelihood of off-label prescribing increases as treatment progresses over time. Okay, so I'm doing okay for time here. So this was essentially a run-through of the 5 quick studies that we looked at, trying to explore what was going on with our prescribers. What we did, to summarize, is that we first confirmed that the prescribing practices that we have ongoing at Wasatch Canyons were worthy of further exploration because they were at least seemingly representative of other national reports. And we asked questions about the prescribing practices to help us understand what was going on in the prescribers' decision-making processes, and what we discovered is that they are sensitive to the level of risk when they're prescribing second-generation antipsychotics to children. We did conclude that prescribers select and prescribe SGAs in ways that mitigated risk to their pediatric inpatients. And that's really the, oh boy. Whoa, there. That's the most important finding. But getting back to that controversy, this is our response to that, and I think that's important too. And that's that even though there's a high rate of off-label prescriptions going on, prescribers who are doing so are thinking about safety. They are trying to make choices that mitigate overall risk to their patients. And that is not something that's captured in that very simple statement that prescribers are using these medications at an extremely high off-label prescribing rate. Oh, and I just want to say we had the opportunity to present some of this in San Francisco and some of it in Toronto. And there we are back home. Any questions? Hi.
Hold on.
No.
Hi. Thanks, Deb. I was surprised that olanzapine had such a high prescribing rate, considering that I think we all know that that's one that we try to avoid to use because of the metabolic problems with that medication.
Well, this was inpatient data, and I think that it falls down a little bit in ranking for outpatient data, but it was consistent with what other hospitals are doing.
Another way that they might mitigate risk is in the partial off-label group, choosing a medicine that the doctor knows is about to get an FDA approval. Were there any medicines that gained an age range or gained an approval, and did the doctors choose a preference for that?
Yeah, thanks for asking that, because I didn't mention that table of medications and diagnoses that I showed you. There has one this year that's been approved. It's Latuda. It's for bipolar disorder with depression over the age of 12. And there are some studies out there that look to see whether pending FDA changes will influence prescribers' rate, but we didn't look at that.
Have you seen any difference in the adverse effects from a medication that's off-label or on-label? I mean, that distinction, off-label, on-label, is to some extent arbitrary. I mean, the off-label means it hasn't been studied. So in your experience with this great data set you have, do you see differences in adverse effects?
I think you're asking about my clinical experience, which is... Right. Well, we didn't look at adverse events. So, I mean, but clinically, I think your question is really well motivated, because I think all of us do worry about adverse events for every time we select any one of those medications from that class. Yeah, yeah.
And sort of related to Paul's question, did you look at how effective the medicines were? I mean, it sounds like there's changes in medication, not infrequently, presumably because the first medicine didn't work, and then that might drive people to to use off-label medication. So, that doesn't sound like that was part of your study, but is that something that you have a way of monitoring so that you can fine-tune the use of medications and compared to adverse events?
You were listening to our groups over the last year, right? So, no, we actually did discuss that issue multiple times. We have a hard time trying to find something that shows progress, although we do have some measures that are implemented right now and have been implemented in the hospital, the transition from paper charts to all electronic charts has made for a kind of loss of data that we just can't fully explore that. Or from that year, we might be able to do that for future years. So.
I don't mean to ignore that side of the room. It's just that Chuck and Paul always sit on this side. Any other questions? No, well, thank you, Dr. McQuade.
Okay.
And Dr. Nancy Murphy will introduce our next speaker. And we have a little, I think, change over on our video here.
That's what I'm going to try. I know.
Stand back.
Good morning. It's my pleasure to introduce Colleen Marty for the second half of this Grand Rounds. Colleen is an assistant professor in our Division of Pediatric PM&R. She is a graduate of the University of Cincinnati, where she went to medical school. And for those of you who've been here a bit, she's one of our resident graduates who slipped away with a thread on her to bring her back. She went away to University of Kansas to do a fellowship in palliative care, and we were fortunate to have you back in the last year or two to join us in comprehensive care and in palliative care. She is the medical director for the Connector program that you're going to hear about. She is also integral to what we do. And the stuff that is not on this piece of paper is just a little piece of Colleen's temperament. She's a team leader. She works with Corrine and Sam and Christy in the Connector program. And the Connector program, whether she tells you or not, had been the most rapid PDSA process you could imagine as it went through its evolution. It's now arrived thanks to her leadership, and she's going to tell us about that. So, Colleen, thank you.
Thanks for the introduction, Nancy, and thanks for the opportunity to share a little bit about this program that's still new and early on. I will kind of share a little bit of the background as to how we came to the model that we are at, describe the model of our current service, and then share some very early data from our first patients, as well as a few stories. I, like Dr. McQuade, have no disclosures. So brief objectives in a short time period. So we're going to just touch on several of these. So define our population, so defining children with medical complexity, review some of the contributors to high medical care utilization in children with medical complexity, as these were factors that helped us design our program and our interventions, and then introduce the Connector service and really share what our aim is and what our interventions are, and then how you can refer patients to utilize our services. So over the last several years, there's been a growing body of literature talking about children with medical complexity, their high utilization of the medical care system, and various definitions. This really was highlighted by a special edition of Pediatrics in March of this year that was dedicated to the care of children with medical complexity. So in that kind of special edition, what was settled on as a definition or presented as a definition for children with medical complexity is children and youth with chronic conditions associated with medical fragility, substantial functional limitations, and increased healthcare and other service costs. This population accounts for a disproportionate amount of healthcare spending. In national literature, it accounts for about a third of all child healthcare expenditures, despite being a very small, less than 1% of the total population, a quarter of all hospital days, 55% of total hospital costs, and 85% of hospital costs for readmission within 30 days. So a significant amount of our financial burden in our healthcare system for pediatrics. There have been many studies looking at factors that contribute to this high utilization in varied settings across the country, and some good data from Canada as well. And some of these things are supported with data, and some are conjectures based on kind of expert opinion and clinical experience that have been presented in literature. So starting with the heterogeneity of the population. Children with medical complexity often have kind of rare conditions that there's not a large population group to look at and really focus structured interventions with clear outcomes. So like adults with diabetes or even kids with diabetes, you have clear outcome measures with hemoglobin A1C where you can measure compliance. There's indications and guidelines to help with intervention and treatment that doesn't necessarily exist for this population because each child is so unique. The individual complexity of the patient also contributes to this. So as I get into our program, we're targeting kids with 3 or more complex chronic conditions that often have several of these factors, so numerous medications and technology dependence. And when you look at those factors combined, coming up with a treatment plan and addressing each of those kind of systems in a way that makes sense for the family and the healthcare system is a real challenge. Numerous medications that are often prescribed off-label and have little evidence base also complicate this management and lead to risk for patients. So as you add more medications, there's increased risk for medication error, which also leads to high utilization, readmissions, and other effects, adverse events. Access to care continues to be a challenge, and looking at our kind of population and our catchment area for this hospital, I think that's one of the things that is really highlighted, and unfortunately not something we can totally address in our pilot program right now, but really trying to match patients with the right care at the right time in the right place. So helping families know when to utilize their PCP office, when they need emergent services, or when what specialists to call when. Those types of things is a real challenge. And part of that also is affected by inadequate funding and availability of home services. For a lot of our technology-dependent kids, despite qualifying for home services like private duty nursing or home health care, nursing for various visits, it is simply not available either in the area they live or just not available even in larger cities. And then probably a biggest one that doesn't have as much hard concrete data in this population is psychosocial needs, which includes social determinants of health and caregiver stress. So there have been many small studies looking at these different areas, but there's not a strong body describing what each of these social determinants of health factors are in this population of patients and their families, and interventions that can actually support that. So these are all things that we considered in trying to design our program. Specifically in Utah, so that's all from national data. And so looking at our own data here in Utah, and this is from Seth Andrews in the Pediatric Population Health group, we can look at our population here. Let's see if I can get this right. So total population, and looking at diagnoses. So the majority of kids have no chronic diagnoses, 30% have a chronic diagnosis. This is our children with medical complexity with 1 to 2 systems involved. So looking just at diagnoses in the chart, about 10.5%. And then what we were focusing on is this children with medical complexity with 3 or more systems involved. That's only 1.2% of our population here in Utah. And if you look at the cost, it accounts for 35% of our cost. So this is our local population that we were targeting. Breaking it down even further, Seth and the PSS group looked at all inpatient admissions and ED visits in 2015 and broke them down into these 5 categories that we saw on that other chart. And we're able to identify that there were over 1,500 unique patients who had 3 or more complex chronic conditions with 1 or more visit to the emergency department or inpatient setting. Each of them saw multiple pediatric subspecialists. 72% saw at least 2 within that year, so pediatric subspecialists within that year. And 81% of these kids identified in this population group were not followed in a comprehensive care program or a care management program. So there was a huge number of kids that are being managed in the community, which can be totally adequate, but are seen in our emergency department, and we may not have communication with their care providers to know what their long-term care plan is, or if there's been discussions about those things. So there's a huge opportunity in terms of numbers. As I've alluded to a little bit from that last data, what was Pediatric Specialty Service, so kind of a population health arm of Intermountain that was led by Seth Andrews and Howard Kadish, really brought forth this idea to try to start a service that identified and targeted these kids to see if care management could decrease overall utilization. So the program aim was to improve value of care for children with medical complexity and to understand drivers of that value, including a shared plan of care, inpatient and outpatient care collaboration, and then tracking providers and families' experiences with the service. Funding was obtained from the foundation to support this program, as well as a research study to track our outcomes and see if it is cost effective and improves patient and family satisfaction overall. Our initial pilot, as Dr. Murphy kind of alluded to, we've gone through multiple changes and cycles of improvement since we've started. So the initial pilot was launched early 2017 after many people who will be, most of whom I've got their names on a slide at the end. So many people before I even got here had worked on this project. An initial pilot started in spring of 2017, and we've had several kind of revisions of that to reach our current model. Initially, it was really an inpatient program or focused program. So relying on hospitalist teams or the inpatient teams to identify patients who met our criteria or attempting to use kind of a risk prediction model and having a care management team housed out of the inpatient case management office try to help write plans of care for discharge home. Well, there were some really great things that worked with that, and the development of some of these shared plans of care could happen quickly. It didn't always involve the outpatient providers. There was some overlap of services, and there were still gaps once we sent the patients home that we couldn't quite identify or couldn't quite understand what was going on in those homes. So over the last year, as several things have changed throughout Intermountain, and we kind of took the opportunity to take a step back, use the restructuring to really look at what we had started and see if there were ways that we could improve that. And I am excited to share what our model is that is up and running and has been quite effective, at least from an anecdotal standpoint, and we're hoping to support that with data. So this is our current kind of core connector service team. There are still many other people involved. It is a collaborative effort with Primary Children's Hospital, Intermountain, and their community care teams, which are adult care management teams that are based in the community, so they're not attached to any clinic or hospital, and are staffed by a nurse, a social worker, and a transitionist who manage complex patients and provide care management and facilitate communication and connection to resources. So it was a model that kind of helped us formulate what we're serving, and is the house of two of our team members. So the University of Utah Pediatric Complex Care Program, and then overall some support from the University of Utah Health Group in terms of our research and statistician assistance in designing some of the measures that we're tracking. Specifically, on the team, many people who are here, we have administrative support from Seth Andrews and Bridget Hanna, who has been our kind of project manager and really helped push us forward through this last little bit. Sean Soyson, I never get it right, who provides data analysis for us and can help us kind of keep track of our patients and know what's going on and see how we're doing as we move forward. And then Christine Morris now, so formerly Aubert, now Morris, who's our full-time physician assistant on the team, who is available to see these patients in comprehensive care clinic when they come in, regardless of what physician they see. So we have that continuity, and then helps write shared plans of care and provide kind of as needed medical input. And then we have Corrine Romero and Sama Mary, who are our nurse care manager and transitionist, who have really kind of taken this on and forged some great community connections to make this work. So describing kind of what are the connector services. So trying to keep this kind of short and focused. There's a lot of things we do, and that will be illustrated in some of the stories that we share about our first patients. But the connector service really is a home-based care management program. So our nurse care manager and transitionist, if needed, can do home visits. So sometimes they'll go together depending on what the home situation is or family situation is. At that first home visit, they do a structured assessment that includes evaluating social determinants of health, overall health literacy, and kind of identifying patient and family-specific goals, concerns, worries, and needs. So the identification of unique goals. They assist in navigating through community resources and the medical system. So I think that's probably one of the biggest thing that our team has done is in identifying those social determinants of health, helping connect families to existing community resources and utilize what's out there in the community to try to resolve those, and then also help guide them through and teach them how to navigate the medical system, who to call when, will participate in those phone calls if need be, but with the goal of teaching families to do that. They have worked really hard in collaboration and communication between providers, specifically with primary care offices. So Corrine Romero and Sam do a phenomenal job of reaching out to care managers in the PCP offices, and that's probably the first point of contact to discuss the needs of patients. They collaborate with them in creating care plans, make sure that we don't have multiple people working on the same problem, so really divide and conquer from that standpoint, and then see if there's concerns from the primary care physician that we can assist with or make sure that communication is going well. They have also connected with insurance care managers as well and case managers. So on a monthly basis, they have phone calls with those case managers to try to help facilitate interventions. And then from a medical perspective, what Christy and I provide are comprehensive medical assessments. And so to provide these children and families with access to 24/7 care based in the hospital, so that kind of subspecialty model. We ask them to come into comprehensive care clinics, so then they have access to our on-call team. We create a shared plan of care document that I will show in just a second, and kind of the details that are involved in that, and then that access to additional support. So the shared plan of care document, this is a blank, kind of a blank version, but it is, the goal is for it to be like 1 to 3 pages long, which is a challenge with children with medical complexity, but really provide a quick summary of the patient. So first, who their guardian or medical decision maker is. So if you see them in the emergency room, who do you need to talk to? Or if you've seen them anywhere, who should you be talking to about this patient? A brief ID of the patient, so brief summary, important alerts, and advanced care planning pieces. So some of these children have pulse, some do not. Many are followed by palliative care teams. Some have pediatricians that have talked about what do you do in a code situation. So really kind of having that in a summary. So even if they're full code, if a conversation has happened, we can give that indication like, hey, this should be addressed because the family is interested in exploring that further. Baseline vitals and physical exams. So for kids that do not fit our usual mold, providing kind of what their normal numbers are and what they look like when they're well. And so this information is often well known by parents, but not documented anywhere. So if you don't have a parent with the child, you don't know. A brief summary of recent hospitalizations, and then problem-based assessment of where things are at. So if you're seeing them for a respiratory issue, you can quickly go to the kind of respiratory assessment, see who's managing their ventilator if it's not our trach vent team, see what the plan was at the last kind of clinic visit, and the date of that is there too. So if it's been a while, you know it's been a while since that's been updated. Currently, and then the last piece is escalation plan. So we provide, based on families' needs, kind of recommendations about what to do, and it depends on the health literacy and savvy of each family. So there's been some patients that it's, if you run out of a medicine, you need to call the pharmacy to ask for a refill. And you should do that 4 days in advance or 5 days in advance. So some are very basic, and others are really nuanced plans that have been provided by subspecialists that we can put in one document about what to do if a patient presents to the emergency room. These are distributed in paper and electronic copies to the families. We are working on getting them to the PCP offices as well, and then they're uploaded in iCentra currently under comprehensive care progress notes, but we are working on a note type that would populate an important patient information, and you could always click on that link to get the most updated form. So that's in progress. So looking at kind of criteria for program participation, and then who can refer patients to us. So we're targeting children ages 0 to 17 with 3 or more complex chronic conditions who have care management needs. And so that's hard to assess just based on review of the chart, but it's in discussion with providers that are already involved in the family themselves. There are no insurance limitations for this service. So at one point in our pilot programs, there were some limitations, and to target the kids and get the number of kids that we need, we've gotten rid of that. We can take patients from really any pediatric specialty. Our exclusion criteria are clinics or services that already provide pretty intensive care management to avoid duplication and confusion. So active hem-onc patients, CF clinic patients, spina bifida clinic patients, transplant patients, neurobehavior home clinic patients where they already have those services. They have to reside within our catchment area because we do home visits, so we can't drive all over the state. And we take referrals from any setting and any provider. So I would say the majority of our referrals recently have come from outpatient primary care office care managers who identify patients with significant needs and social complexity. This is just a map of the catchment area. So it's all of Salt Lake County and the southern portion of Davis County. So before I go into some of our data, I just wanted to share one, I think anecdotes at this point, because we don't have a ton of data, can be the most helpful. So one patient that really illustrates the value of a home visit and sitting down with a family. So this is a 2-year-old who had trisomy, or has trisomy 21, AV canal defect that has been repaired, Hirschsprung's disease with a colostomy and takedown, and some continued kind of gut issues with severe chronic constipation, dysphagia with G-tube dependence, and lots of feeding intolerance. He was from a family that had moved here from Africa. During his initial hospital course, his parents separated, and his primary caregiver was actually his oldest sister, who was 20 years old. He had been in and out of the hospital several times, and there were frustrations from the inpatient teams that the family wasn't necessarily present, or it was hard to get the parents there to know what to do next or to talk about the plan of care. And when we talked to the family, the parents said, well, his older sister knows him best. She's his primary caregiver. We want her to talk to the medical team and make decisions. So that was a really first easy step to say, okay, let's do the paperwork so that you can show up and say, I can make medical decisions for my brother. So that was one of the first things. The other thing that we discovered on that first visit was that this sister, who was his primary caregiver, was going to travel out of the country for a month or longer to get married, and was going to leave this child in the care of his mom, who had not actually provided any of the hands-on care for the entirety of his life and to this point. And Corrine, our nurse, reached out to his insurance care manager, his primary care office care manager, got everybody on the phone talking, and had come up with a plan and gotten approval to have intermittent home health services during that time period where the sister was gone. So there was this plan kind of in the works. He ended up coming into the hospital for a medication error provided by mom, which kind of further solidified the fact that he needed extra support. And due to the complications related to that, ended up staying at South Davis while his sister was out of town. But I think just that example of getting care managers from every setting on the phone that can share information really did change things that we could provide at home, where in the past it would have just been no. So that's just one example, kind of thinking about care collaboration. Looking at current data. So we don't have a ton to share right now. We're still working on learning how to pull data effectively from Healthy Care, and then we just don't have a lot of time to look at. We have 25 active patients, 5 who are pending enrollment, so families we're trying to reach out to and set up kind of that first home visit, and 2 new referrals. So this is our most latest data that we haven't quite worked through. We categorize patients based on acuity level, just to try to figure out what our workload is and make sure that we can continue to bring on new patients. And this is assigned by, again, Corrine and Sam on admission or on enrollment. So high has contact with home visits or other kind of supportive visits more than once a week, so once or more a week. Medium is kind of every 2 weeks we're having a home visit or in-person contact. And then low are families that have kind of stabilized. We've plugged them into different resources, and SOM as our transitionist kind of helps just monitor. So offers periodic phone calls. They have access to him in the office, and he can then kind of get whoever needs to respond to this call. So this is our current patient load. We've received many more referrals. Many are outside of the catchment area, don't meet our criteria. We've only had 3 families decline our services because they felt like they were doing well without any additional support, and 3 that we were unable to reach after many, many tries, and even trying to catch them in person. Looking at our number of visits, and these are really provided by Colleen and SOM, so there's been 51 home visits so far for that total of 25 patients. 7 care collaboration meetings, so those are meetings where the patient isn't present, but the medical team sits down and makes a plan for these patients. 29 visits in a medical facility, so that's clinic co-visits, whether it's somebody from our team going to help facilitate communication or visiting while the patient's in the hospital or at a long-term care facility. And then 10 where our team has supported families at community agency meetings, whether it's trying to apply for disability services or adjust Medicaid, so providing that kind of extra knowledge and support to families during those visits. One of the things I'm excited about seeing is looking at social determinants of health, and we've been able to use the Connect to Health screener with our patients. This only shows a total of 12 patients, so that we do have some siblings in the same family, and then some of these forms that were captured on paper before we had a system in the electronic medical record to easily pull. I think, so knowing that it's only 12 families, half of our families have issues with food, living conditions, paying bills, accessing public benefits, and transportation. And those are all things that really impact their ability to provide the care that we request from them. So in terms of accessing these benefits, Colleen and SOM work really hard to connect families with community agencies and use the community resources to support this, so that as a hospital and healthcare system, we're not the only ones supporting these families. So using what else is out there. We have identified goals that our care management team kind of works for, and about 185 goals have been identified. Some are just steps in addressing each of these issues. About 60% have been met, 15% are progressing, and there are some that we just run into barriers along the way, so we're kind of altering goals along the way. But for just a few months of working through this, I think we're doing a relatively good job addressing those needs. One last kind of story, and this is really about the social determinants of health piece. One of our first referrals was a 5-year-old child with Bacterial Association with multiple comorbidities related to that, but the one that was kind of most apparent when we showed up at the house was trach vent dependence. So tracheostomy with nighttime vent dependence. This little girl had lived in long-term care facilities for the majority of her life. She did have some short stays at home, but always ended up back in the emergency room, a long PICU stay, and then back to a long-term care facility. Shortly after discharge, our home visiting team made a visit, and were able to identify several barriers. One, mom had a vision impairment that could affect some of her ability to provide cares. Neither parent had a great understanding or great health literacy or English literacy, despite many efforts by the medical team to explain what was going on. Because of some of their English literacy and just general literacy issues, they did not understand what mail they were getting, and were at risk of having their electricity turned off. So this is a ventilator-dependent child who's going to have their electricity shut off, would be at risk for losing heat in the winter, had lost their home nursing. So after being home just a few nights, they had one visit from the home nurse who didn't feel like the house was an appropriate care. There were some bugs everywhere, so that they wouldn't come back. So they had lost their home nursing support. Dad was the one who was having to provide all the care, but because of that, was unable to go back to work. and then were at risk of losing their home as well. Corrine was able to reach out to the HEAT program, so one of the local community programs, who helped step in and identify the family as one that couldn't lose electricity, but even went a step further and really helped get furniture and supplies for this family. So their house is set up in a much better place. The bugs have been taken care of. They're working on getting home nursing back. Corrine and Sam will sometimes get photos of the family's mail asking, like, is this important? Is this something I need to do? They've helped the family access some other social services as well, and really, really have set this family up for success, we're hoping, in the future. So it's an exciting thing to look back and say, okay, we're making some progress case by case with this. And then just one really brief mention, because this could be a whole topic on its own about how you measure success of a program like this, and what do you look at. We have a team working on the stats behind this, and how do we really measure what our outcomes are. So there is a university research study attached to this. It's IRB approved. The team is led by Howard Kadish, and we are studying both kind of patient and family experiences as well as utilization data. Sean provides some pre-post data as we go, so we can keep track of kind of how many ER visits and hospitalizations and length of stay, just to see how we're doing along the way. And then we have some statisticians that are helping us figure out how to see how this impacts the population as a whole, or at least in our community, how that impacts population. As I mentioned before, there have been a ton of people working on this. This is only a few names. I could not fit everybody on here, so I appreciate the input from so many people that have helped us kind of develop our program and get to where we are today. And then just, I want to leave you with all of our contact information. And if you have patients that you would like to refer, you can reach out to any of us, email anyway. We're on SmartWeb, we have phones, we have email, all of it. So thank you.
I think we have time for one question. Of course, you're in the middle of the row.
My one question has two parts.
Okay.
So first of all, I just want to say this is super exciting, because what I like the most about it is the home visit part. Because we have a disease-focused healthcare system, we tend to think everything happens in the hospital, and really everything happens at home. That's where everybody spends the vast majority of their lives. So I think that's really super exciting part of your program. The second thing that I wanted to just mention is that the work that your team is doing is by nature both extremely rewarding and extremely frustrating, I'm sure, and it depends so much on the relationships, and relationships develop over time, which means that you need to keep your staff, which means that you need to attend to their well-being and happiness, and just want to plant that in your mind that you have a plan for that. But thank you for doing this. It's wonderful.
Thank you.
Well, I had a request from Dr. Giordino to end a minute early, and I listened to my boss. So we will wrap up, but I'm sure Dr. McQuade and Dr. Marty will take questions offline. Thank you.